Tonight's presentation is first principles, and I can, without hesitation, say this is the most important webinar we have ever had. It's that big of a deal. And I think you'll agree when we're done, these are the things you have to master. So, without delay, first principles, the foundation of the integrative diagnosis system. What are first principles? You probably have heard this term before if you listen to business podcasts or just philosophy. There's science, math, there's all sorts of utilization for first principles. The fundamental idea of first principles is how to start at the start. You just have to begin at the beginning, start at the start. As obvious as that sounds, respecting these principles, starting with the fundamentals, just isn't done in most of healthcare, and especially not in musculoskeletal healthcare. So a first principle is a basic, foundational, self-evident proposition that cannot be deduced from any other proposition. This means it is as fundamental as it gets. It's almost like the US Constitution. We take these truths to be self-evident, and then we make a list of things that we want for society. Similarly, something that is basic, foundational, and self-evident, you will see that as we list and go through these principles, that they are irrefutable because they are self-evident, and you cannot deduce them any further. I spent a lot of time boiling down to get to these principles, that I kept having a very strict rule. Is this a build off of a basic, or is it the most basic? If I think it's the most basic, I then ask myself, can I make it shorter? And can I stress test whether that is the most basic idea? So the 7 things I'm going to present to you fit this first principle definition. Secondarily, in sciences, theoretical work is said to be from first principles if it starts directly at the level of established science. So we are starting at the level of established science, as well as self-evident basic foundational propositions. Established science, for example, pictures of adhesion on endoscopic procedure. That isn't self-evident, but it is established science. That thing exists, and the evidence is the pictures. The secondary evidence is a surgical reduction creates an improvement in symptom and function. So that's science. And it does not make assumptions. This is the critical piece that anybody who's dealing with a technique in manual medicine or musculoskeletal healthcare, the technique is always built on assumptions. I went to Logan College of Chiropractic, and one of the techniques we did was Logan Basic, and it was built on a set of assumptions. Not first principle established science or self-evident basic propositions. So that's what a first principle is. So why are first principles so important? And again, so that we can start at the beginning, start at the start. You cannot start in the middle. If you don't use first principles and you use second principles, third principles, fourth principles, or just assumptions, not any real principles at all, then you're starting in the middle. The reason people do this is because it feels shorter, but it will compromise the things over here on this slide. When you get all of your thinking and doing from first principles, you improve your accuracy, which means you improve your results, which means you reduce error. At the end of the day, all of this simply means you have a better reality match. When you're dealing with healthcare, you have to see what is there, not what you wish were there, not what you want to be there, not what you think could possibly be there, but what is in fact there, supported by evidence. So the entire ID system is based on first principles. This is what makes it so useful and so robust, is that it's simply a representation of reality. It's no coincidence over the last 12 years that we've been teaching this, that it continues to be supported by additional scientific findings. I had no idea anybody was putting an endoscope in the deep gluteal space and finding adhesion, or finding adhesion in the accessory nerve, or that the best, most reliable way to measure dorsiflexion is using the toes to wall measurement. I just ran across this research again the other day, and I'm like, man, it's right there. There's tons and tons of examples. So when we build something from our view of reality, and other people come along and afterwards, and they support that with their data, it's remarkable. It continues to demonstrate that we're seeing the truth, and that's huge. So we're reality matched. Secondly, and this is a big deal, depth and fluidity of understanding. Depth means I can explain layer after layer after layer of what's happening. When a patient gives you a history, if you were to mark every single thing they said, you could explain each of those things based on their diagnosis and how they're loading. Fluidity allows you to go from one concept to another. You've got such a well-populated conceptual network in your head that you can go from, oh, that's a sclerotogenous referral of L5S1, to, oh, that's hamstring protective tension, to that's sciatic nerve entrapment. You can go from concept to concept, that's axis of rotation. Whatever it may be, you can go as deep as you need to, and you can switch from thing to thing with fluidity. That is what allows for mastery. In other words, you will not and cannot get to mastery without first principles. You will never be able to memorize that much of the body. So that's why this is the most important webinar we've ever done. Just to add to this, right? When you have first principles and depth and fluidity, and you're accurate and you're reality matched, you can apply these principles in novel environments. The ability to apply first principles in a novel environment, what this means is a lot of the people you see day to day are similar to something you've seen before. And as Mark Twain said, reality doesn't repeat itself, but it rhymes. I completely agree with that. But what I've seen in doing 1,800 hours of coaching, and the majority of it with difficult clinical cases, is that we can apply these first principles in a novel environment, meaning a diagnosis that you have not come across before, and be right. So you may have not seen diagnosis before. You certainly haven't seen this presentation in this way with this host of history and exam findings, but you still get to the right answer. You can still interpret the data. So the difference here between using first principles, again, first principles allow you to understand and have depth and fluidity and pursue mastery and function in a novel environment. You understand it versus memorize. Most medicine in healthcare, you are encouraged to memorize. What do we do in school? Here's the 4 things you'll see that are deadly. So memorize, this is their symptoms, memorize it. When you match this list in your head and you have 3 out of 4 of these, then you need to do an MRI. That is simply memorization, and it doesn't allow for depth or fluidity or novel application or anywhere near mastery. My girlfriend's mom was in ER the other day. She's fine, but it was interesting that My girlfriend and her mom are in the ER, and my girlfriend is telling me the story of what they did with her mom. My girlfriend works in banking, so she does a lot of spreadsheets. And she was like, it was just like these doctors were only going off of an Excel spreadsheet function. And I was like, that's exactly what it is. You've memorized a chart and you have a function. If you have this symptom, it must be this. It's ridiculous. And it does not allow for proper history. And it's a mess. So memorization is basically makes you a fancy spreadsheet, or as I often say, you're a vending machine can do your job. Punch in these buttons and get this result, where we need to understand what's happening. So now that we know what first principles are and why they're important, we will get into the 7 first principles that are at the absolute core of the ID system. Number 1 is load and capacity. And in the very original website years ago, I had quite a bit on this, and I backed off on it so that you can get your procedures and techniques down. But this is and always will be the root of musculoskeletal healthcare. So load is how much force you put through parts of your body. And that can be at the whole body level, meaning I ran 10 miles. It can be at the tissue level, meaning my knee cartilage underwent 10,000 repetitions at 3 times my body weight each, something like that. It can be part of a tissue. Where I flex forward, I may load a certain part of my disc or end plate or annulus. The point is, load could conceivably be measured. We don't do that clinically, and in a lab you can measure some of these things. But the point is, when a force goes through a tissue, that is load. So load has a magnitude, which is an amount. It has a time, which is a duration. It has a frequency, how often that happens, how much rest is in between. So that's what load is. It can function at all different forest versus trees, so to speak. And then capacity is the ability of a tissue to handle load. An example is if I took out my knee cartilage and smacked it with a hammer and repeated that till it broke, it might do 10,000 reps. If I took out someone else's knee cartilage and smacked it with the same hammer, it might undergo 100,000 reps before it's damaged. So capacity is the ability to withstand the load without breaking down. That's load, and that's capacity. Most pro athletes have tremendous capacity because you can't get decades of use in the same sport at high levels without that tissue being able to handle it. This is why you might be a brilliant pitcher in high school, but then your labrum tears, and then your rotator cuff tears, and then you're never the same. You had more skill than someone else, but you had less capacity, so you never made it to the pros. So load versus capacity is the most fundamental equation in musculoskeletal medicine. In fact, it is the root of 100% of musculoskeletal problems. You can have that on the capacity side, and you can have it on the load side. But if something is damaged or degrading, it is because load is exceeding capacity. So very simply, on the right side of the slide, health is when load is less than capacity. Disease is when load is greater than capacity. That's it, but it is so profound, it's ridiculous, because it is useful all day long. When I ask you to take a history and we're supposed to get symptoms and load, this is the load part. What did you do? What have you been doing? Is another way of asking what load has the tissue undergone. And then when we ask about how you felt with that load, we're asking about capacity. Because often when you exceed capacity, you create a symptom. So all we're trying to do as providers is get load to be under capacity by reducing load and or increasing capacity. So a little detail here. When load on a physical structure or system exceeds its capacity, damage and dysfunction is the result. This should be page 1 of every musculoskeletal medicine textbook. Those are the things we need to understand intimately. Because the job of the provider is to identify areas of increased load. Simply put, where is the load coming from? Where is the high load in your system? Coupled with, where is the decreased capacity? If I have high load and decreased capacity, what is that? Disease. Patients come into us with disease and dysfunction. Therefore, I am instantly looking for increased load and decreased capacity. I'm not looking yet for a disc injury, for a nerve entrapment, for anything else. This is how fundamental this is. If you're doing the memorization thing, you start thinking about diagnosis. Loading capacity is your anchor. It keeps you understanding the important parts. So if the job of the provider is to identify, which is to diagnose the increased load and decreased capacity, then treatment by definition must decrease load and increase capacity. This way we get you to go from disease to health. So I first identify, second, remedy. That's profound, but that's it. In a nutshell, that is what we do as musculoskeletal diagnosticians and then treatment providers. That's why this is number 1. If we stopped right now and you had a better appreciation of load versus capacity on a scale, and you were always thinking, how do I improve capacity and how do I decrease load, then you will be a great provider. Lastly here, because there's so much misperception around pain, and we'll get to this again later, but in regards to load, pain is a load management tool, full stop. Musculoskeletal pain is a load management tool. It is the innate response to load exceeding capacity. Because when load exceeds capacity, you get tissue damage. Your body does not want more tissue damage. Simple example, you roll your ankle, you damage your ligament, that creates pain so that you stop, and then as it heals, you limp. And the more capacity that ligament recovers, the less you limp automatically. Your body is constantly measuring what tissue is damaged and it has a diminished capacity, and how much load can I put on it. Pain is your important link between load and capacity. That's why we're interested in symptoms, because they tell us something about load and capacity. Hopefully you can see how we're going to start weaving these things together. Second, first principle, respect pathology. I don't know how, but our professions have gotten so far out of whack that this is number 2 on the list. And it's simple. You have to know what's wrong. And know is not a small thing. Knowing, not thinking, not assuming, not guessing, not hoping, but knowing. So let's unpack this. Number one, these are definitions. I'm a definition guy because I want to make sure we're all on the same page. So this is actually kind of fun. Respect. What is the definition of respect? An act of giving particular attention. It simply means you focused on something. So when I say respect pathology, this means you need to focus on it. You need to give it your attention. And that's what we do with our diagnostic sheets. That's what we do with our history sheets. That's what we do with our exam sheets, is get you to focus, to respect pathology. So then what is pathology? This definition is just awesome. The study of the essential nature of disease. Really anything that can go wrong in the human body that creates a disease state is a pathology. And especially for the structural and functional changes produced by them. So you have a disease that creates a structural or functional change. For the musculoskeletal system, that is beautiful because that's what we assess, structure and function. So this simply says respect pathology means you have to pay attention to the structure and function of the musculoskeletal system. You can't do one or the other. It's weird that people even think a school of thought is, well, I respect function but not structure, or vice versa. Both. Respect pathology, respect structure, respect function. In other words, respect whatever isn't working. So why is this the second principle? Because you have to respect pathology to arrive at an accurate, complete tissue and pathology specific diagnosis. That's the filter through which all treatment decisions are made, is the diagnosis. If you don't respect pathology, you can't get the diagnosis right, because it has to be accurate, complete, and specific. You can't respect something, you can't get there without respecting it. So a few basic questions here is, what is the job of that tissue? What's it supposed to do? Then is it capable of doing that job? If your glenohumeral joint and the related structures are supposed to lengthen and move, and it can't, your shoulder abduction's out here, your joint isn't capable of that motion. And you need to figure out exactly what tissue is the problem. Because the tissue there, say this is infraspinatus, that tissue's job is to do an eccentric contraction to maintain the axis of rotation. If it isn't able to lengthen as you come to 100% and it stops the motion, then that tissue isn't doing its job. It is not capable of that. And then why and why not? So does it have adhesion in it? If it does, it makes perfect sense, but you're going to have that limited range. This is just thinking in a very basic way. We can go through the same example for any tissue and pathology in the body, whether that be a degenerated disc, whether that be a stress fracture, nerve entrapment, something that's weak, stress, anything. We can use this model. So you've got to respect pathology. Number 3 is respecting symptoms. The symptoms don't matter if you don't respect pathology. This is where 99% plus of musculoskeletal providers fall down. They try to interpret symptoms without respecting pathology, without considering load and capacity. So we're building through our first principles. You can't have number 3 if you don't have 1 and 2. So now we're ready. So respect symptoms. What are symptoms? To me, symptoms are data. There's really good information in your symptoms. Why? What and why? Because they tell you about load, capacity, and pathology. If you can speak the language of the symptom, you can determine what's the load, what's the capacity, what's the pathology. Again, pathology is a disease state of structure or function. Again, we've got respect, so we have to pay attention to a symptom. And a symptom is something that indicates the presence of a disorder. So that's a subjective experience by the patient. It's a sign if the doctor sees it. Again, but super powerful. Patients come to us because they have a symptom. So what do we do with the symptom? How do we break this down? We pay attention to the location of the symptom. And this, everybody learns in school, but I don't think anybody but ID providers does systematically in practice. The symptom location, it can be dermatomal, it can be sclerotogenous, it can be cutaneous nerve, or it can be local tissue. That's the bulk of your flow chart. You have to know those symptom patterns and what tissues they relate to. Location quality is where we start solving the problem with our history. Then we look at the quality. Certain tissue types will create certain qualities of symptom. And lastly, we look at the intensity of the symptom. So location, quality, and intensity. These are all forms of data that tell me something about load, capacity, and pathology. Because the tissue that's symptomatic certainly has diminished capacity and almost always also has high load. If I can identify that tissue, I can start to figure out what's dysfunctional and what has a structural deficit. So respecting symptoms is a huge deal because it tells you something about the pathology and the load and the capacity. Those are the three basics of the symptom. But additionally, we pay attention to when the symptom shows up and when it goes away. So after we know where, what, and how much of a symptom you have, we know what makes it worse and what makes it better. Again, this goes more toward load, capacity. It's more data. No wonder that the symptom and the load, what makes it better, what makes it worse, loading and unloading, is 5 of the 7 first order history pieces. This is at least 80% of your diagnosis. So if you don't respect symptoms, you can't do this. If you don't respect pathology, you can't respect the symptom. If you don't respect load and capacity, you can't do anything else. See how they're interweaving through the system. Number 4, so that clears load and capacity, pathology, and symptoms, which is huge by itself. You've got to know those things and you have to think in those methods. Number 4 is a lateral sidestep, which is it doesn't matter how much you think about that. If you don't measure it, you can't really track it or even determine how bad it is. So without being able to grade a problem or track its progress or change over time, you're still powerless. So number 4 is to measure everything. Underneath on the left side of the slide here, if you can't measure it, you can't manage it. That's it. I did a million things for years before I developed ID without measuring. And even while I developed ID, we didn't measure enough. And now our goal is to measure everything that can clinically be measured. So if you can't measure it, you can't manage it, which means you have to measure it because treatment is measured. Second, if it's worth doing, it's worth measuring. Take the time to measure it. It kills me to know that people are out there eyeballing straight leg raise. You can't. You will be off by 15 degrees. When you measure it, you'll be plus or minus 3 degrees. So measure everything. And here's some examples of respecting this first principle. We collect pain scores. The numerical pain rating scale is the most tested, most reliable measurement for what's happening in the patient's body. This says I'm experiencing this amount of pain, 0 through 10. And then we look at it and say, okay, well, what have you been doing for load? Where is the remaining symptom? So we have a numerical rating scale, which tells us something. We know what your pain score is at its worst and at its best, more data. How long does it take to show up? And when it does show up, how long is it there? That's time to onset and duration. So measuring pain, not just giving it a number, but giving it a number superimposed on certain situations. It's worst first thing in the morning. It feels best when I get up and walk around. It hurts after I'm at work for 3.5 hours. It lasts for 4 days. Measure not just the pain score, but the data around it. It's absolutely critical. If you sit on the couch and do nothing and your knee feels good and you run 10 miles and it hurts, you have the same problem and a very different pain score. So don't take pain in isolation. Use this surrounding data. That is something you're doing in your initial history and in your daily SOAP note to demonstrate to the patient, yes, your symptoms are X and your load is Y. So the point of the measurement is so that we can assign values to the other first principles, like symptoms and load. Cool. We also do the functional tests. So to measure the ID tests, do all of the ID tests. This allows you to demonstrate progress. And I always say have a progress party, which is a necessary communication. But it also measures progress to the provider as well as the patient. And interestingly, what's progress? It means you have decreased load and increased capacity. That is progress with their case. That's the beauty of it. So even in number 4, our fundamental principle of measure everything, what are we measuring? The first 3 principles. So by knowing your function, because what's function? If you function well, your body is in a low load environment. If you don't function well, your body is in a high load environment. Think of the blood pressure analogy. Why is high blood pressure bad? Because it increases load on the cardiovascular system, which results in damage and then acute episodes like strokes and heart attacks. So blood pressure is a functional test because it measures load on the cardiovascular system. The ID tests are functional tests because they measure load on the musculoskeletal system. That's how simple it is at its core. Measure your function. Awesome. All right, next up here, pathology grading. So since we're measuring your pain, we're measuring your function, we also need to measure your pathology. And there's a million ways to do this. But we started doing this last year with adhesion, which we can grade as none, mild, moderate, or severe, 0 through 3. We also have the tendinosis grading scale. There is what's called a Perfman grading scale for lumbar discs on MRI. You can grade osteoarthritis with mild, moderate, or severe. You may measure the size of a disc herniation. Often on the radiology reports, you'll see that this is a 7 millimeter and various other measurements. So grade as much as humanly possible the extent and severity of the pathology. That's part of why we started doing this with adhesion. Because before that, and it blows my mind, we only started doing that this year, yeah, you have adhesion. Or you don't have adhesion. What? What? How much? That's necessary. Because here's one of the pieces. We're often trying to determine what pathology is blocking a test or causing your functional limitation. So for example, with straight leg raise, I might not be sure if it's a space-occupying lesion of a disc preventing neural root movement or sciatic nerve entrapment. So if I've got a straight leg raise that's 45 degrees and mild sciatic nerve entrapment, that doesn't compute. that's more likely a disc. If I have a 80-degree straight leg raise and mild sciatic nerve entrapment, that is congruent. So this is part of why we measure everything. It's not just to demonstrate progress to the patient and the provider, but it's to determine relevance of pathology as well. Cool. So we got pain scores, functional tests, grading of pathology, and then we have load. Measure the load. And clinically, this is a little bit of a challenge, but pick the thing that's most relevant. How many miles per week do you run? How far into your run is it when things start to hurt? Or how many hours per day do you sit? How many sets and reps do you deadlift? Whatever your provocative activities are, you want to have a measurement for those. It may be as simple as, yeah, I bend my head sideways and this lights up my shoulder instantly, and when I stop, it's gone. That's still a measurement. So when we look at load, we need to have it with a measurement. So hopefully you can see that measure everything, as generic as it is, breaks down into your pain score and its environment with other details, your functional tests, your pathology, and your load. So we're not measuring silly things. We're not taking x-rays and measuring every little asymmetry that you have. We're not putting you on two scales and measuring whether one has more than the other. We're measuring the important things. And I actually debated putting an asterisk up here after everything, but it would have been awkward to say measure important things, right? And leave the unimportant stuff undone. I think that's even more fundamental than a first principle. Don't do unimportant shit. So I couldn't, in good conscience, put that in here. Do the important stuff and measure everything you do. And lastly, measurement forces accountability. You are accountable. This is the hard part. When some people first learn ID, they go, oh yeah, I have to make these tests better. And then they realize their skills are lacking. And instead of doubling down on their skills, get upset and go back to doing something else. Believe it or not, that happens. They don't like the accountability. I like accountability. I want to know whether what I am doing is helping you. So we measure because that forces us to be accountable. It provides information about the direction, better, worse, or same, and the amount, a lot, little, none, of change. So information about the direction and amount of change is absolutely critical. That's the root of why we measure everything. So the rule is measure everything. The reason is so we know if it's changing. And these are the ways in which we measure it: pain, function, pathology, and load. Again, if it's worth doing, it's worth measuring. If you can't measure it, you can't manage it. First principle, number 5, is diagnosis. And we've got tons and tons of colleagues that will either just outright say a diagnosis is unimportant, it doesn't matter, it's for insurance. That's sad. We've got other folks that their diagnosis is always subluxation or take your pick. But the diagnosis, as basic as it is, needs to be based on what tissue and pathology is present in your patient objectively, not based on your hopes, your fears, or your training, but just objective. So it's tissue and pathology specific. It's also a list that has to be complete and accurate. That's a diagnosis. Anything other than that isn't. A syndrome isn't a diagnosis. Here's an example. This patient has 3 diagnoses. This is the list. And each one involves a tissue and a pathology. This is what your diagnostic list should look like, and I want you using the diagnostic worksheet to arrive at them. Here, an example of a tissue, and a tissue just means a piece of anatomy. L5-S1 disc. The pathology is an annular tear. You can suspect that clinically, or you can have it on an MRI, or both. Second diagnosis, tissue is supraspinous ligament. Pathology is adhesion. That would be diagnosed by having a limited QLF test and then palpating the interspinous space and also palpating with the instrument. The adhesion, furthermore, would be graded on our 0 through 3 scale based on how much you found. The third diagnosis, the tissue is the facet joint, and here we know L5S1. This would also say bilateral or left or right, and the pathology here is mild osteoarthritis. Again, you can have imaging of that or clinical signs and symptoms of that. So this is an example of what a diagnosis needs to look like. Now that we have 3 of them, it's a list and it's tissue and pathology specific, the last part is prioritizing this. So this diagnosis might be, in your expert opinion, 50% of their problem. This one might be 30% of their problem, and the last one might be 20%. The point here isn't that you have to have some granular understanding where it's 52% and 28%, etc. It's that you have to know what's most important. What is the biggest structural or functional deficit in what tissue and how bad? That's most of their problem. And we call this the magic wand. And this is how we establish this. If I had a magic wand and could get rid of diagnosis 1, how much better would you feel in function? 50%. Cool, right? This is great. That's the method of establishing priority. So everybody in healthcare makes a diagnosis. It just doesn't mean it's useful. Here's why ours is useful. This is a representation of reality that has data to support it. I picture myself on cross-examination. I would take on anybody in the world with my lists. Yeah, this is this. This is here because this was in a sclerotogenous pattern, which is a known referral zone for the annulus, and it matched the L5S1 pattern. Also on history, they had XYZ, and on the remainder of the examination, they had ABC. And we can go through all of those details. So the point here is the history, exam, imaging and special tests in response to treatment establish and refine the diagnosis. Again, there's 4 categories for diagnosis: history, exam, imaging, and response to treatment. People run into trouble when they don't use all 4. Again, if you don't have these first principles and you can't take a history and your exam isn't looking for tissue and pathology, you might just get the MRI and go, oh, look, there's a disc. That must be your problem. That's horrible. Or you look at the imaging and go, oh, there's a disc. That doesn't matter. If you don't have these 4 parts, you cannot arrive at a complete and accurate diagnosis. That's why we do it this way. So again, the diagnosis is an ordered, prioritized list of the most important tissue pathology combinations causing the problem. To accurately make this list, you must know all of the tissue pathology possibilities. This is a big deal. Again, if I were in a school giving exams, would throw a dart, would hit the pain diagram somewhere and can make a list of all the tissues that go there, and then make a list of the possible pathologies and how they would present on history and exam. In other words, what would happen when you load that? What would happen when you unload that? What would that pain pattern look like? That is using these first principles, all of them. Cool, so that's diagnosis. Number 6 is treatment. You can see how we're building, right? Without a diagnosis, treatment doesn't matter. It's random. It's been proven over and over for decades. If you don't have a diagnosis, you cannot provide effective treatment for musculoskeletal problems. We're going to explain why right now. Treatment has to be safe, effective, and durable. These are the guidelines the FDA uses to allow a drug to be sold. Same guidelines I use to do treatment in manual medicine. But before we get to safe, effective, and durable, we have to explain what treatment is. Treatment is anything recommended, which is advice, or performed, which is generally manual therapy, by the provider that will improve capacity and reduce load. Look at that, we're back to fundamental principle number 1. It is not treatment if it doesn't improve capacity and reduce load. The musculoskeletal system, you must be able to do those things because that's what created the problem, and that's the only way to work yourself out of the problem. So by looking at this as a cortisone injection treatment, my answer is no. It will make you feel better. It actually diminishes your capacity and increases your load because the symptom was protective. So you're going to go out and do more if you feel better. You're going to create a worse problem. Is it good, safe, efficacious, and durable treatment if a year later you're worse off? Of course not. So it doesn't meet the bar for the definition of treatment or the fact it needs to be safe, effective, and durable. So what is treatment? Based on that, if it's improving capacity and reducing load, what we do is manual therapy to restore tissue health and mobility. We do exercise to restore balanced strength. So getting the tissues to move reduces load. It normalizes load through the body by restoring range of motion. Exercise makes the muscles balanced and strong, which increases your capacity. And then we have advice, which is generally load management. Here's what to do to create a healing environment where your load is less than your capacity. That's the point. If you look at advice that way, it's no longer a surprise or guesswork. Why do I recommend somebody sit, slide, lean, and we want your spine in relaxed neutral? Because that's the lowest load position it can be in. So that's why we want you there. And then I invented sit, slide, lean to put you there. These are fundamentals. So safe, and these are basic things, but they still need to be described. So in order for something to be treatment, it must be safe, and that rewards outweigh risks. In manual medicine, there's almost no risk. You're going to be sore, you might bruise if somebody does it wrong. Outside of that, we're talking 1 in a million, 1 in 100,000 stuff. Effective, and I went to the FDA website and tried to look for these definitions, and they all have a little bit of circularness to them, which I respect, right? So here, the definition of effective is it must have a statistically significant between treatment difference, meaning from placebo to treatment or from the existing treatment to a new treatment. On a valid measure of clinical sign or symptom, then that's effectiveness. So all a treatment has to do to be effective is work better than nothing, better than placebo, or better than another option in a statistically significant way. And how do we determine better? Your sign or symptom is improved. So if your average pain score in your study starts out at 7 and the placebos go down to 5 and the old medicine goes down to 4 and the new medicine goes down to 3, then that's proven effective. That's it. And that makes sense. Lastly is durability, which is simply to say the treatment effect must last long enough to be considered valuable. So if I gave you an adjustment and you felt better for 3 minutes, that doesn't have any value. If I give you an adjustment and it lasts a day, well, if you're the one in pain, you might decide to get an adjustment each day. If it lasts a week, I think we'd all say there's some value there. How much? You'd have to figure that out. If it lasts a month or a year or 10 years, obviously that all has value. So value can be a judgment call, but the longer something lasts, the more valuable it is. The point in having this in the definition of treatment is those studies that look at immediate changes, like with kinesiotape, A, there aren't any, and B, if there's something that tends to be slightly statistically significant, it's only immediately after. Well, what's the point if by the time I get home, I don't feel better? And number 7, communication. This is the last first principle. And yes, communication is important, but it's last. Here's why. Your communication needs to be clear, short, and meaningful. These are the three things you must communicate, or methods of communication. Over here on the right side of the slide, there is always a knowledge asymmetry between the patient and the provider. Meaning, we know more about the body than they do, but they usually know a lot more about themselves than we do. So there's an asymmetry on both sides for different reasons. So the patient has to communicate with the provider, which is normal. We just ask them questions. But the provider communication is what I'm most concerned with. We have to communicate some of our knowledge. I've underlined this because ID providers tend to be detailed people. The patient doesn't need the details. So we have to communicate some of our knowledge to ensure the patient understands their problem, their diagnosis, understands their treatment options, that they're comfortable. They're like, okay, I feel safe. I feel understood. So understanding is the intellectual part. Comfortable is the emotional part. You need to make sure they have both. That then sets them up to make healthy choices. That's the goal of communication. Understanding, comfort, and good choices. That's the root. So now here's the three pillars. How we clear. Your language must be clear. Strong language, not weak. Don't say, I think you have adhesion. You might have adhesion. It looks like. All of those things eradicate weak language from your vocabulary. Use strong language. You have adhesion. You have a disc injury. Not it looks like. Well, no shit. If it's on the MRI, it looks like it because it is it. Go with the strength. Simple. Speak simply. Your patient is in pain, they're emotional, and you're probably a stranger. Communicate simple. Familiar words. Don't use multifidus. Say your back muscle. Okay? That's clear. Short. Use the fewest words possible. That's it. If you were to write out what you just said, you could probably cut it in half. Do that. Here's an example. Your nerve is stuck to a muscle. It's supposed to move and it can't. I will unstick it and restore healthy motion. When I say that, do you want to argue with me? Do you have 10 more questions? Or are you just like, hey, sounds great? That's what we want our communication to do. They understand and they're comfortable and they're set up to say, yes, please, I would like treatment. Awesome. And lastly, meaningful. There's two parts to this. The patient needs to instantly understand all of the words you use. Don't ask them to think. I was recently reading a book on FBI interrogator / investigator. Super interesting stuff. But about 20% of the book is redacted. And you're reading along and then you've got this just black line. And then you pick it up and you're like, I don't know what just happened. When you use words the patient doesn't understand or has to think about, picture that redacted part of a document. You cannot have redacted or non-understandable words. It doesn't make you look smart, and it only makes them less comfortable and less understanding. So no redacted parts. Number two, your communication must satisfy their needs. I'm not going to shut, and I've done this, guys. I vividly remember explaining posterior knee stability to a 20-year-old who had a problem when she ran. And I remember getting all done thinking, that's beautiful. I turn around and look at her and she's just checked out. I have made all of these mistakes. So my communication did not satisfy her needs for 100 reasons. I broke all of these rules. But you've got to know what their needs are. Some people just want to know that you care. Some people want to know they're in the right place. So some patients are factual, some patients are emotional, some are fearful, some are dismissive of you or the facts or whatever. You must address their concern. Don't shove details down someone's throat any more than you would shove emotions down someone's throat. Identify in the history or the consult what's important to them and speak it back to them in clear, short communications. All right, so we're going to go a few minutes over here. I hope you guys can hang out here. First principles are what you do all day. And again, this has been the most important seminar of the year because this is what you do all the time. And whether you know it or not, if you're in musculoskeletal healthcare, these are the things you should be doing all day. So these are the keys to your success because they are the keys to reality. This reality matches. That's how it's successful. So everything you think and do must be in accordance with these principles. So what is the diagnosis? Go back through all 7 principles. How does X treatment reduce load or improve capacity? On which tissues? Is there a capacity deficit that's slowing treatment response? That's really what you're saying when you're like, boy, this is going slow. I wonder if they have a food allergy or if they're stressed or if they're not sleeping. You're saying, I wonder if there's a capacity deficit in their recovery that's slowing their treatment. And as a quick possibility here, if anybody wants to put a treatment into the chat and we can run it through these first principles. Any treatment at all. I don't care if it's surgery, right? So I'll go first. Knee replacement. What is that with first principles? It's load and capacity. Number 1. Number 2 is the pathology. Your knee is so badly damaged, the bone, the cartilage, list the parts, that its capacity is so low that load with ADLs creates tremendous pain and dysfunction. So what do? We take out the broken pieces, put new ones in. The hardware has a greater capacity than your original tissue. So we improve capacity, it's treatment, by putting new stuff in. You no longer have high load on damaged tissues. So that's what a knee replacement does. So we can walk through all of these, but we are over time, so I'm just going to get to the last couple slides here. There's just 3 more. Systems that use first principles, right? This isn't unique. Math uses first principles. Language uses first principles. You can do division. You can divide 7 by 1047, which you've probably never done before because they're random numbers. But if you understand division, it's simply a function of principles. Math has basic principles. You divide these figures and see how many times this goes in. You can also pronounce words and read books. You can read sentences you've never read before because you understand the fundamental components. English has 26 characters as its first principles. And then they go together with certain second-order principles and third-order principles so that you can read a story. Healthcare needs the same. Part of my ID mission is to have diagnostic reproducibility among providers, because we're all looking at reality. We don't have anywhere near that. So again, the application of first principles to achieve depth and fluidity of understanding, even in a novel environment. That's what first principles do for you. Now, since we talked about the rules, who breaks the rules? So we've got second, third, and fourth level principles. And you know what? These actually aren't principles, because we can build off the first order principles. And most of musculoskeletal healthcare is using second, third, and fourth level assumptions. For example, the chiropractic subluxation. Look at the list we just made and compare that to the statement, adjustments are good for back pain. Back pain isn't a diagnosis. It's 100 different things, and adjustments are good for it. Well, is it treatment? Is it safe, efficacious, and durable? Does it improve capacity and reduce load? Now you have the vocabulary and the tools of thought to evaluate this statement. Likewise, the pain science guys love this one. Lots of people have degeneration without symptoms. So your symptoms can't be coming from your degeneration. Says who? The asymptomatic people stay home. The symptomatic people see the doctor. So if that's 4% of disc injuries, that's the 4% in my office. I look at this and it baffles me, but they don't have first order thinking. They're up around a third order assumption is what that is, and that's a shame. So that's chiropractic and pain science, not to leave physical therapy untouched here. If it's tight, you should stretch it. Tight isn't a diagnosis, and is stretching a safe, efficacious, and durable treatment? If so, for what? Does it increase capacity and decrease load? No. Think how rudimentary this is, stretching. What they're trying to say is if a range is restricted, force it. Good luck with that. Secondarily here, if it's weak, you should exercise it. So if it's not producing enough force, we'll just make it do more. We may not even measure the first one. If you have knee pain, we'll just assume your vastus medialis is, quote, weak and give you exercises to strengthen it. Again, no safe, no efficacious, no durability, no tissue and pathology specific diagnosis, no improvement in capacity or decrease in load. Subluxation causes disease. We're back on the chiropractic thing again, right? What is that? It's not. You can't even define the first one very well, and it certainly isn't the cause of all disease. And then treatment for non-specific low back pain. I'm sorry, non-specific low back pain is not a diagnosis. And all of the research is about non-specific low back pain. Who says you can rule out 4 things, cancer, fracture, infection, cauda equina, and then proceed to treat? That's like a 5th level, just bogus craziness after seeing these 7 first order principles. Cool. All right, guys, on a personal note here, today, believe it or not, December 19th, you'll see it on the bottom of my diploma here, is my 20-year mark in practice. So it's been crazy, but I could not be happier with where my career is, with where ID is. I want to thank everyone who has dedicated themselves to clinical excellence and using the ID system. The first 20 years are just getting warmed up. What we've done in the last year and the last 2 years, we're on an upward curve here that's going to be insane. It has taken the full 20 years, and that's since graduation, right? So add 3.5 years to it for school, for me to make this list for you guys tonight. It's that much work to distill it down into those principles. 10 years ago, I had what I called the 14 laws of musculoskeletal healthcare. This list of 7 things is better. It's more concise. It's more useful. So the first 20 years has produced this, as well as all the level material and all the stuff we do in small group and all the in-office assessments. We are going to make this system more useful, more implementable, have a smaller valley of death, if not, maybe get rid of it entirely someday. So I'm looking forward to the next 20. So that'll be cool. And so guys, that is it for tonight. I hope you enjoyed participating in this presentation as much as I enjoyed putting it together. This one was just a lot of fun for me to sit down and work through these details and refine it and leave it for a couple days and go back to it and repeat. But I think you have the most distilled, most useful list we've ever had of the most fundamental principles that exist. These are timeless. They have always been in existence and will always be in existence. We will see you in the new year, and I will come up with a theme for 2019. So stay tuned. Thanks, guys. Good night.